appreciate the insight he will share with us in today's webinar on Eustachian tube dysfunction. We will touch upon various facets under his expert guidance, such as exploring the Eustachian tube dysfunction and its epidemiology, navigating the complex anatomy, emphasizing a holistic role of the Eustachian tube beyond its opening, highlighting the critical importance of middle ear aeration, understanding diagnostics, differential diagnosis and therapeutic option of ETD, presenting the balloon Eustachian tuboplasty procedure with tuba-vent balloon catheter, and talking about outcomes and complications proven by numerous studies of BET, and finally he will share his personal experience. After the presentation there will be enough time to answer all your questions and you will be provided answers by Professor Di Martino. You are already invited to post your questions during the session using the chat function. So now it's time to hand over to Professor Di Martino. Thank you.
Hello dear colleagues, my name is Ercole Di Martino and it is my pleasure to welcome you to this Spiegel and Theis webinar about modern Eustachian tube dysfunction diagnostics and therapy. After my presentation we will have enough time for discussion, so feel free to ask questions and I'll be happy if you join us for a vivid scientific exchange. There we are. Here is my disclosure, and now I want to introduce you to Sue, a fascinating lady I met about 12 years ago in Chicago at the Natural History Museum. And what thrilled me were not her impressive teeth, but when you look on the lower left, you see her stapes. And when you compare it to human stapes on the opposite side, first of all you see this tremendous dimension, but what is more important is the evolutionary aspect. It shows us that this system for middle ear aeration and also for hearing is very old, very well approved and very efficient. But still we have problems, and these are the Eustachian tube function problems we are talking about. And how are they defined? Well, typically we have a oral fullness, maybe pain, maybe discomfort, maybe popping. And when we look in the ear with our microscope, we see probably tympanic retraction, or we see fluid in the middle ear. And if this lasts less than 3 months, we talk about an acute problem. But if it lasts longer, and this is in many cases, we have a chronic Eustachian tube dysfunction. And we have to distinguish from this the Barrow challenge. The Barrow challenge is more a clinical diagnosis because these are patients who have problems, for example, while diving or while flying. To make the diagnosis, we can use a pressure chamber, but this is restricted to academic settings because not everyone has a pressure chamber. So it is mainly a clinical diagnosis. And the other very important diagnosis we have to distinguish is the open tube, the patchless tube. So characteristic here is hypophony and the movement of the eardrum just going with the breath. How big is the problem? Well, we talk about 6% patients worldwide, more or less, and up to 60% of our patients report problems while flying or diving. For the US, we have data that there are 4 million children and 12 million adults affected. To make things more complicated, there is a recent study by Guy and co-workers from Halle University who did research on patients for autosurgery. They found that up to 80% patients with the middle ear pathology lack a detectable eustachian tube dysfunction. So, what does this mean? And how can this happen? Well, we know that the duration of the eustachian tube opening is about 0.2 to 0.4 seconds. The frequency in adults is reported to be 1 to 1.4 openings every minute, and in children it's about 1 every 5 minutes. As we know, as a matter of fact, the ET opening is not the whole story. So what we need to understand this fully is we need a more differentiated approach. The function of the eustachian tube is the regulation of the middle ear hemostasis. And what happens is pressure equilibration. We see a regulation of the gas exchange. We have protection against bacteria, but also against reflux and against sound. And we have a drainage of the middle ear secretion. We have to look at the eustachian tube as central part of a functional entity. And that comprises the nose, the nasopharynx, the eustachian tube itself at its very center, and the middle ear and the mastoid. Well, to complicate things further, the anatomy is not very easy to understand. And besides that, we have other factors. This is mucosa. We have the quite complicated mechanics of the eustachian tube opening. We have the surfactant factors, we have immunologic and neural control, and we have the gas exchange of various gases like nitrogen, CO2, or also oxygen. As a matter of fact, as you can see in this endoscopic picture, but also here in this histologic sample, the eustachian tube is not a tube, but it is a middle ear cleft. And here I want to take you to a dive into the eustachian tube, which is a video that was made from my right ear about 15 years ago, and we are now in the cartilaginous part. We proceed slowly, and on top you see the black hole, which is the entrance to the bony part of the eustachian tube. I have to admit that it was not a pleasure to have this done. We did it under local anesthesia, and it was not very pleasant. Well, you see, we need some time, and we have to be very diligent and cautious. And very soon we will enter the bony part of the tube. Yes, here we are. And now we go forward. And what you see very soon is the entrance to the middle ear cavity. And we will pass this. And then we will have a very interesting picture, because this is the view from the back side of the eardrum, and the light you see is an endoscope we put in the ear canal just to demonstrate where we are. When we now proceed further, you will see stapes and incus, and here we are, and I think this is a very, very interesting insight, a very interesting perspective for the middle ear, or in the middle ear. Well, we said, and I think this is scientifically proven, that it is more than just the eustachian tube opening. We have to We have four main components. And this is Eustachian tube as a functional valve. And the function is the optimization of the sound transmission by leveling variations in the middle ear and to make short openings active and passively. The second function, or the second component, is the mucosa of the middle ear and the mastoid. Both are important for gas transfer and gas exchange. We have the eardrum that acts as a flexible buffer, and we have the mastoid that also acts as a rigid gas buffer. And to complete this, there is the autonomous neural function control by baro and chemoreceptors we found in the eardrum and also in the middle ear mucosa. Well, what is true that gas exchange in the middle ear shows net gas absorption, and that means we have a tendency towards under pressure. And to demonstrate this, we see at the figure at the lower left. This is an experiment Professor Pau did about 20 years ago. He had a constant monitoring of the middle ear pressure by tympanometry, and what he did is he didn't swallow for 2 hours, 2 long hours. Really brave what he did. And you see how the pressure in the middle ear is constantly sinking. So this is what also happens in real life when we have aeration problems with the middle ear. And this is in part driven by the pressure gradient of the gases between the middle ear and the venous capillary gland. In case of inflammation, the gas exchange increases and of course the under pressure rises. Well, middle ear aeration is important for the acoustic properties of the ossicular chain, and the composition of the middle ear gases I could show is different from the normal atmosphere. So this tendency towards under pressure is always persistent. But middle ear pressure needs to be at the same level at the outer hemisphere. Otherwise, we have an impairment of the ossicular movement. So, how does this work and how can we check? Well, we look at these findings here that are very common to our surgeons. When we look at left side, we see a completely retracted eardrum in the lower half and the right tympanum. The eardrum sticks to the promontory, but the upper part is quite normal. On the right side, we see a cholesteatoma with destruction of the bone, but the eardrum itself is completely normal. And in the middle we see what we encounter as surgeons very often. This is after reconstruction, and you see there is a quite atrophic eardrum. We have a small perforation that occurred by the time we see the prosthesis, and this seems to extrude or be close to extrusion. So this is the problems we have to deal with. Well, how comes? We have to look into the anatomy, and then we can find the reasons, or some of the reasons. First of all, we have a lower inferior anterior compartment that is mainly represented by the middle ear cavity.
Vâng anh ạ.
And it is
Dạ
connected
vâng,
via the
vâng. Cái
anterior
file gửi
isthmus
anh trên tele
between tensor
cái file đấy nó
tendon and the stapes
cái file đấy là của cấu hình
from
của
the
việc khác.
upper posterior
Có nghĩa là
compartment,
vâng, cấu hình của
which
cấu
is
hình
mainly
file trên tele gửi anh.
comprise epitympanum, antrum, and mastoid.
Dạ vâng, vâng, cái đúng theo cái file.
And the isthmus here is the
Dạ vâng,
posterior
vâng.
isthmus, which are the posterior malleus
Lại.
ligaments and
Dạ
the
vâng,
bony
ok, cảm ơn em.
bone surroundings. So these are the narrow passages, and when they are blocked, then of course we have a problem with the aeration, and that also is a main explanation why we have so different pathologies of the eardrum. Well, how can we diagnose? And this is not very easy. There are more than 60 methods, and I think every year there's another one, a new one, and please, maybe I have not found every method, so excuse me. Well, of importance is endoscopy, just the visual finding we have, and also the movement of the eardrum. We have tympanometry, and the very nice 9-step inflation-deflation test, very well described by Charles Bluestone in his book. We have broadband tympanometry. I worked a long time with sonotometry, pressure chamber I mentioned, and etc. All these diagnostic only give small snapshots. And the sad truth is, there is not the only one and only tool. There is no universal tool for diagnosis. So we have to find a consensus, and this was internationally done in 2015. And Tyson reports that currently no accepted tests for Eustachian diagnosis exist, and we should rely on a combination of symptoms and signs, but also the majority of tests hasn't had a good evidence. And of course we have the same in Germany, and I was a participant of the German Consensus Conference in 2017, and we consented to rely on tympanometry and EPD-7, a very good questionnaire that was done by McCall, was published by McCall in 2012. And we have a German variation of this by Herr, and we use these means to establish a proper diagnosis. So what to do? Well, technically we use otoscopy and endoscopy to see if we have a eardrum movement, and of course to see the structure of the eardrum. We try, or we ask the patient to perform a Valsalva maneuver. Can you do it in a controlled way? Is it possible, yes or not? Tympanometry is part of our work. We lift patients in the questionnaire, we EPD-7, we do audiometry, and we always ask about our challenge. That means, do they have troubles with flying or driving? What we found is that the effect of the grommet is a very, very good indicator for the obstructive Eustachian tube destruction. And it is trivial to say our success depends on patient selection. Well, we have to look at the differential diagnosis, and here we have the lymphatic drops. We have the superior circular canal dehiscence, and we have most important attachments. A number of other instances cause problems in the original station, but they are not situated in the tube, such as adenoids, which is very often in children, nasal polyps, allergic rhinitis, rhinosinusitis, and not so rare laryngopharyngeal reflux. The diagnosis of a patulous tube is mainly based on clinical diagnosis, and is based on history, patient history, of course, the eardrum movement, synchronous breathing is a signature. When you look at the eardrum, you can have very diverse findings like bulging, but also atrophic and sometimes even normal eardrum, and also tympanometry is very diverse. We have a number of options. First of all, conservative therapies. We advise our patients first to use nasal decongestives, steroids, especially in the children we use balloons, and in the adults we advise to do the Valsalva maneuver about 50 times a day. And another maneuver is the Eppendorf maneuver, where you open your mouth and try to swallow. Well, then we have interventional symptomatic therapies, which is mainly the paracentesis and the grommet, and I said it is very important to find the obstructive Eustachian tube, because if the symptoms go away after a grommet, then you know you get the right diagnosis. And we have interventional causal therapy options. This is for the obstructive Eustachian tube dysfunction. The balloon dilatation, and it's scientifically very, very well proven, as I will show in the literature later. And of course, we have other not so well proven options for the open tube, for the patulous tube. Well, there are many therapy options, and some of them have a historic character. For example, as the guiding wire Volker Janke used in the 1980s, this nowadays is obsolete. And the same is true for I have personally no experience with the tuba clean device. Grafting can be a method for patulous tube, and then we can use either collagen, Teflon, or fat. A laser tuboplasty is promoted by some colleagues, and also the plug-in with the patulous tube can work. And the most established therapy for obstructive Eustachian tube dysfunction is the balloon dilatation. Well, here you have a picture in a model, and you see you insert the catheter in the cartilaginous part of the Eustachian tube. You may not be anxious about harming the bony part, even if we use a pressure of 10 bar, there is no danger. This could be shown in many studies, and this is the reason why we don't do CT scans anymore. You can insert the catheter either both with the endoscope in the same nose, or you can do them on both sides, or you can use it transorally, something I will show you later. The indications for a balloon dilatation are first of all pressure equilibration. Other indications are recurrent middle ear effusion with grommet extrusion. We do it in patients that have problems with Valsalva and show a middle ear pathology. And we do it in some patients, in selected patients with middle ear pathology that have recurrent perforations, that have revision tendinoplasties, and sometimes we try to prevent an extrusion of prosthesis beforehand. Well, here are some pictures of a recent operation I did, and you see with the right ear. You see I insert the catheter, and after waiting 2 minutes and blocking it with 10 bar, I extract the blocked catheter, and sometimes you see the mucus coming, and I know this was a good measure. And I want to show you also, when you look in the choane, you see the mucosa there. It's quite quite bulging, So you can see that there is a problem too, and this also makes a problem when you go through the nose, and this was a oral operation. Well, let's come to results and complications, and there's a very good, from my point of view, one of the best studies done by Dennis Pro and co-workers in 2018. He studied 139 patients over 21 years of age, and it is a prospective randomized study, so it is a very high evidence. And they compared Eustachian dilatation plus medication drops against medication alone. And they controlled first after 6 weeks. And we could see that tympanometry was better in the BET plus group with 52% improvement, whereas the medication alone group only showed an improvement in 30% patients. After 2 years, in 60% patients, the tympanometry was normal. And they also used the ETDQ7, and there 56% of the patients in the BET plus group reported significant improvement, and it was only 8.5% in the medication alone group. So this, I think, is an impressive result. And there are some other good studies. There are retrospective, and there is the studies mainly from the Bielefeld group with and here we have a retrospective study over 5 years with more than 600 patients and more than 1,000 years, and the improvement here was between 70 and 82%. And another very interesting study I think is the study from Matthias Pusch from the own group, because they were the first one to study children, and their children were between 4 and 12 years of age. This is a retrospective study in about 167 patients with nearly 250 years, and the improvement in this group was 63%. So it works also in children. This is a very interesting finding. Let's come to the literature and my personal experience. First of all, Eustachian tube dilatation is not an experimental surgery, but it is very well proven, and there are more than 200,000 procedures since 2009, and the number is steadily growing. There are some complications that have been reported, such as emphysema, minor bleeding, tinnitus and oral fullness, and also otitis media with effusion, but the rate is very, very low. Helsman did this in a review about 1155 patients, and he published this in a Laryngoscope in 2018, and I think even the complication rate is going down because we get more and more experience. As I said, CT scan is not necessary. My personal experience is I operated more than 500 patients since 2012, mainly adults, but also few children. I started with children over 10 years. As diagnostic tools, I regularly use tympanometry, tubomanometry, and in the last years I used sonotometry, and all patients got ETDQ7. When we look at the results, there are excellent patients with our challenge. We published a study on the German ENT Congress 2014 in professional divers, and 42 professionals that had problems in their job, and we had an excellent improvement rate of 87%. In patients with normal obstructive Eustachian dysfunction, our success rate is about 70 to 75%. In patients with chronic ears, the results were more mediocre affair. About 50% of the patients improve, but 50% still not. And I found in oncologic patients that undergone radiotherapy only disappointing results. Here I think the blue is not too helpful and we rely mainly on the grommet. We also found complications, of course. In these patients, I had 2 times otitis media with effusion after a defect. We had 3 times the increase of tinnitus. 6 patients reported persistent oral fullness, but no emphysema and no bleeding. Maybe the oral fluids and also because I didn't have a proper diagnosis about the patches, but this is to be discussed. I myself am modifying my approach because I started transnasally and now I go transoral. I find it much easier. For my experience, I can say the Eustachian tube patient, Eustachian tube dilatation does not solve all problems, so it's not a silver bullet, but in the majority of our patients, it is definitely worth a try. Let's come to Petrus tube that we see here, and the typical finding with synchronous to breathing. What can we do? Well, plugging has been discussed. Also, I think grommet is very helpful in these cases, which is easy to understand. From my point, ligature is obsolete, and grafting can also be discussed. Well, when we look at the literature, there's a very nice study from Brian Watt about the outcomes at the management of Petrus tubes. And what he did, he studied 80 patients with 4 different interventions. That was balloon, that was uroxil apatit, there was laser surgery of the Eustachian tube, and also augmentation. And the criteria for success in the study group was symptom-free interval for 12 months. The result was that in 80 patients, 241 interventions during this time were necessary. And what we have to say is that it is quite complicated and quite tricky, and we had a balloon dilatation of 52%, and in the obliteration patients, in 81%, a grommet was necessary as a second intervention. So what is the conclusion? First of all, let me say anatomy and function of the Eustachian tube is very complex and still not completely understood. And the consequence is that we have no universal diagnostic tool. And as I could show, there is no universal therapy, but Eustachian tube dilatation is a very well proven and effective therapy for obstructive Eustachian tube dysfunction. So it is a safe and rational option, and we combine it with a grommet, what we like to do in children. We have to rule out the Petrus tube beforehand, because otherwise we run into trouble. The other lessons I have learned is to handle the middle ear mucosa more careful than I did before in the surgery, because of the receptors we have there. And the other thing is that we do a pre-op treatment in chronic ears before operation to try to improve the this can be Eustachian tube dilatation, but this can also be medication with nasal drops. So now I am at the end of my
Thế
presentation,
là
and
sơ sơ
I'm
cái quán
now
là
looking
vườn quán là vườn
forward
đấy,
for our discussion.
chỗ quán mà em bảo đây, chỗ này ra chỗ đấy nha. Nhá, khoảng 5 giờ 5 rưỡi à? Ok.
So, thank you so much for this really great presentation, Professor Di Martino. When I think we have technical issues.
Any questions? So we'll be open for that.
Yeah, you can have now the time to post your question in the chat function provided by Zoom, question and answer function. So just type in your questions, and we are very happy. We have the time now to answer those questions by Professor Di Martino. So I see already some questions coming up. So a very nice presentation. Then the question is, what is your treatment protocol for petroless Eustachian tube?
Yes. Okay. Can you hear me? Yes, I hope so. So my treatment protocol is, first of all, we start with nasal decongestion. We do this especially in children first because we want to start conservative. But of course, we have administered many patients from outpatient departments from other doctors, so they have already tried this. And when we know that this was done, then we start with the treatment for the Eustachian tube. So usually we take nasal cortisone again, and if this is the last chance of them, then we do the DDT. And we do it also in children, as I said, and quite successfully. Of course, it does take some time to convince the parents to do this, because this is a treatment that is mainly used in adults in Germany. But we are quite successful in convincing them, because in many instances it saves future operation. And what we also do, we combine it with a grommet. We should ask, why should we do this? Because we want to have an instant success. The grommet is done after 6 months, and this gives time that the Eustachian tube is recovering from the swelling that happens after the dilatation, and so we can have an optimal result of this.
Thank you so much. So there is plenty of other questions here coming up in the chat box. Another one is, do you have any particular reservations or seen any worsening of symptoms in scuba divers?
In scuba divers, up to now, not yet. Actually, we were quite lucky with it. Actually, scuba divers was the group who were most successful. Yeah, it was a very high successful rate, and my co-worker, who is also a semi-professional scuba diver and an ENT doctor, so we closely monitored his patients, and they were very, very happy. You know, they are in Germany and they came from Brazil and so on for the DDT, and so this was very successful. So I have no particular reservation to this. No.
Okay, great. Then another question from a doctor who says, I don't usually place the grommet in the same procedure in regards to Eustachian tube dilation, because I think it might be difficult of the realization of Valsalva maneuver, or at least to control it. What is your experience about it, placing a grommet?
We do it quite often, to say frankly. So I don't share this reservation. Well, we don't know yet, because there is no control study if you should do it or not. Does it really affect the result? It should not, but I think the psychological aspect is quite important, especially in children.
Okay, then we have another question. Would you consider bowel challenge ETD as a sort of precursor for developing more chronic obstructive eustachian tube dysfunction later in life?
Yes, I would do, but I cannot really say what are other indicators, so that some people go that way and others don't. It's like in many diseases, you know, you have some people who have some kind of light or moderate symptoms in the beginning, but some do recover and some do not. So yes, I do regard it as a precursor, but it's just this is just a mild hindsight, I would call it.
Then we get another question here. Would you consider a long-lasting tube such as a T-tube rather than a grommet or a parera? Yeah, that's the question.
That depends on the case. So if we have a chronic ear, I tend towards a T-tube because I'm not really sure if the BET is the silver bullet in this case. As we said, the success rate is 50%, and so with a T-tube, at least in a chronic ear, you do not do anything wrong. And even if it goes out, who cares? I mean, yes, I tend to do T2, but I know many other colleagues who do not. This is more, how you say, it's
regarding the preference of the doctor.
Yeah, this is more my personal preference. Probably I'm a bit old school with that, but I look back on more than 30 years of orthosurgery experience, and it worked quite well.
So then we have another question here. Will you offer a balloon dilatation in patients with eustachian tube dysfunction symptoms, but normal audiogram and normal tympanometry?
Yes,
That's really
yes, I will. Yeah. This is also sometimes these are the patients also with bowel challenge symptoms, and yes, we do offer them. Yeah. But very important is to rule out that they do not have a patulous tube. This is really one of the most important differential diagnosis, because then you really do harm to the patient.
Okay. Then somebody's interested in the technique to approach the eustachian tube transorally. So this seems to be not like something where doctors are interested. Can you a little bit share about it?
Yeah, well, okay. I showed the slide how I do it. I put a catheter through the nose, and then we elevate the soft palate, and from there I go with a 70-degree angle. I go through the mouth. So I have the 70-degree optics on one side, and on the other side I place the catheter, because then the view is better. So I go crosswise more or less. If you go on the same side with both instruments, it's always more tricky. This is also what I experienced in the nose. That is why I changed first from putting one instrument in one side of the nose and the other one in the other side. And the same was true in the mouth.
Okay, great. Then there's another question. So if you do the BET, do you do it under local or general anesthesia?
Yeah,
You have maybe also experienced before.
I have seen people. I have seen videos from colleagues from Denmark who do it under local anesthesia. You saw the movie with the eustachian tube passage, and that was my ear. And I can say that my personal experience was not the most very pleasant one. I think the local is not. Well, is one component, but very important is also the sedation of the patient. So you give them midazolam so that they don't remember afterwards what really happened. My personal experience with the local, and you can trust me that I had a very experienced colleague, was not very pleasant, really. So I do it under general.
Okay, yeah. You know it by yourself, so to say. Yes, so there's some pain involved. Yeah. So then there's a voice here. Based on the experience shared on my experience slide, it seems like the sooner you are able to identify patients with Eustachian tube dysfunction and provide them with a DET, the greater the effect of the treatment. What do you think about this statement or this question?
I try to be a bit more conservative. Generally spoken, yes, if you start early, your success will be early. But first of all, I try all conservative means before I advise a DET. You know? Because you have to convince people that they are doing the right thing. And sometimes you have your results if you are persistent and if the patients cooperate. You know, if you say take this and this, you don't really know, you cannot control if they do it. So you push them into this direction, and when you see it doesn't work, okay, then the DET is great.
Then we have another question here. DET can be done in children. Are young patients with cleft good candidates for DET?
Are young people
Cleft palate?
with cleft palate?
Yeah. No, young patients with a cleft.
Yeah, okay. Cleft palate patients are very special, and because the anatomy is completely altered. So I think in these patients, I tried this in this patient, but I was not successful with cleft palate patients. You know, all the mechanics doesn't really work, and so I'm not really convinced if this really works in these patients. I had a few of them I tried, but I was not successful in any of these cases. At least not I didn't have persistent success.
Good. So somebody offered you to call him privately, but we will manage that later on. So it seems that there's a lot of interest here. So we have another one here. When a patient has typical symptoms but no diagnostic findings, how do you proceed?
How do I proceed? Well, of course, if I am sure that he doesn't have a patch in the tube, then I tend to work towards, after of course having explored all the conservative means, I tend to offer a DET. Yes, because I think I will not do harm to this, and in the best situation we will make a profit for them. So it's very good.
Okay, great. And there's a question regarding bilateral balloon dilatation, or kind of doing one after the other. So somebody is asking if bilateral balloon dilatation is a problem, or if you then have the patient two times a day.
We regularly do it. You know, if you have a bilateral problem, we try to solve them bilaterally. It's just one procedure. It's far more convenient for the patient. You know, I may not say this, but and the company may not like to hear it, but we use the same balloon if we can. You know, so no problem. We can do it. And we do it very well.
Okay, great to hear that. Good, I think looking at the time, we are good to go. For here, the audience, if you are interested in trialing the tubavenous balloon catheter, or you would like to receive more information, such as the latest scientific white papers or application videos, brochures, and so on, just contact Spiegel and Theis via the website. We have a contact form, or you can just give us a call. So there's always opportunities there. And thank you so much, Professor Di Martino, for spending your valuable time and answering all those questions. I hope you had a good time, and sorry again for the technical issues we were facing. And then have a good day. Thank you.
Yeah, thank you very much. Thank you to Spiegel and Theis for the organization. Very well done. And thank you for your interest, dear colleagues. If you have questions, don't hesitate to contact me. I feel happy to answer those. And make your experience with the DET. And I think you have a very good need for solving many problems in this area. Thank you very much. So bye-bye and have a nice day.
Bye.